Cancer. So these are some terminology that you have to remember and understand. Tumor or neoplasm. So this basically means a new and abnormal growth that is uncontrolled and progressive. So it means a new mass. Angiogenesis. Angiogenesis is the formation of new blood vessels from existing vessels. So this results in new vessel feeding the growing tumor with oxygen and nutrients, which will allow the tumor to grow even bigger and for cancer cells to invade nearby tissue to move throughout the body and to form new colonies of cancer cells called metastasis. A medication that is used to inhibit angiogenesis is bevacizumab or Avastin. So tumors can be classified as either benign or malignant. Benign tumors are basically neoplasms that are non-cancerous. They usually will have a uniform size and shape, and they don't invade the neighboring tissue. Now, malignant, on the other hand, these are cancerous cells. So cancer cells that invade surrounding tissue. Usually their size and shape, they're very irregular, and so for the most part, they are quite different from the normal cells. Metastasis is the term used to describe spread of cancer from its original site. Anti-neoplastic agents or chemotherapy are basically drugs used to treat cancer. Cell cycle specific anti-neoplastic drugs that are cytotoxic during a specific phase of the cell growth cycle or cell cycle. Cell cycle nonspecific, on the other hand, are anti-neoplastic drugs or drugs used to treat cancer that are cytotoxic in any phase of the cell growth or cell cycle, so nonspecific to the phase of the cell cycle. Nadir is a term used to describe the lowest point in any fluctuating value, so the lowest white blood cell or platelet count during chemo, or most commonly it is used to describe the lowest level of neutrophils, which is a form of white blood cell, during chemotherapy. There are different classes of anti-neoplastic agents or chemotherapeutic agents. The first one that we're going to talk about are the anti-metabolites. These are considered cell cycle specific. So their role in cancer treatment is by substituting folic acid and purine or pyrimidine. So this will inhibit cellular growth because it inhibits those essential or critical chemicals or compounds that are needed for cell production or DNA synthesis. So this inhibits cellular growth. The result is decrease in synthesis of the DNA, RNA, and proteins, which then will result in cell death. An example of this drug is methotrexate. So methotrexate is a folate antagonist, and this has to be administered concurrently with leucovorin. This is an antidote for folic acid antagonist, which will decrease the toxic effect of methotrexate. By administering leucovorin, it will allow for cells to have folic acid rapidly, and so it will prevent the death of normal cells when we administer methotrexate. These drugs are used for solid tumors, hematologic cancers, and autoimmune processes or disorders. Examples of drugs in this class is Trexel or methotrexate. Mitotic inhibitor is a cell cycle specific drug. These drugs or anti-neoplastic agents exert the activity before or during mitosis. That's why it's named mitotic inhibitor. This will decrease the cell division and produce non-functional parts of the cells, causing cell death. The common uses is for solid tumors and hematologic cancers. Example of drug under this class is paclitaxel or Taxol, which is obtained from a plant. Topoisomerase inhibitor is another cell cycle specific anti-neoplastic agent. The way it works is by binding to the DNA, and so the topoisomerase 1 complex, and then it impairs the religation or reattachment of the DNA strand, therefore causing the DNA strand to break. The common use for this form class or type of anti-neoplastic agents are ovarian cancers and colorectal cancers. Examples of drugs drug under this class is topotecan or Hikemptin. Alkylating agents are cell cycle non-specific. So the way it works is by altering the cell DNA, wherein the alkyl group attaches to the DNA molecule and prevents the correct bonding or joining, therefore causing cell death. The uses of these drugs are combination, so it's used for many types of cancers, but this is not usually a standalone treatment. This is often used in combination of other chemotherapy treatment. An example of drug under this class is platinol or cisplatin. Next is your cytotoxic antibiotics. These are cell cycle non-specific anti-neoplastic agents. So the way they work is that the drug is inserted between two DNA strands, so the DNA helix or that spiral becomes unstable, and it also blocks the synthesis, causing cell death. This is used for solid tumors and hematologic cancers. Examples of drugs under this class is adriamycin or doxorubicin. Something very important that you have to remember when it comes to doxorubicin is that this can cause left ventricular failure or heart failure. So this is a cardiotoxic medication. It can affect the cardiac output, so it can decrease the cardiac output. That's why it is very important to have a measurement of the ejection fraction before and even after the treatment, because we know that this drug can impair the cardiac output or basically cause heart failure. So general side effects of anti-neoplastic agents include nausea, vomiting, hair loss, fever, malaise, and fatigue. It can also cause renal damage as well as bone marrow suppression. Those are the things that we need to keep in mind when it comes to what are we monitoring. So what labs do we need, right? So if we know that it can cause renal damage, then we may want to check for our BUN and creatinine. If we know that these drugs can cause bone marrow suppression, then we may want to check our CBC or complete blood count to see how's our WBCs, your platelets, as well as red blood cells, because again, we know that it can affect those organs. Some management of some side effects include the following. So at times, the anti-neoplastic agents can cause allergic responses. So the medication that we use for that is Benadryl or diphenhydramine. At times, there can be some inflammatory response from the anti-neoplastic agents. The drug that we use is dexamethasone or Decadron, which is a glucocorticosteroid. A very common side effect of anti-neoplastic agents include nausea and vomiting. The drug that we use for this specific type of nausea and vomiting is ondansetron or Zofran, which is a serotonin receptor antagonist. As mentioned earlier, it is very important to follow our labs, especially knowing the possible side effects of this drug. So it is important to follow our renal labs, making sure that the patient is properly hydrated, especially when they're actively being treated. And also, we need to make sure that we're adjusting the drug doses based on those labs that we are monitoring. In addition, we also have to maintain the blood pressure of our patient depending on their baseline, as well as minimizing nephrotoxic agents. So basically avoiding agents or drugs or anything that can affect the kidney function. An example of it is if we know that we're going to be administering chemotherapeutic agents, we may want to avoid administering IV contrast dye to this kind of patients, because then again, these drugs are already nephrotoxic, and so if we add another drug that's also nephrotoxic, we are risking losing that kidney function. We also have to remember that these drugs can suppress our bone marrow, so we need to make sure that we limit the exposure to infectious sources such as large crowds, maybe fresh fruits and vegetables, uncooked meat or meat products or uncooked seafood, because this will increase the risk for getting opportunistic infection as well as actual infection from that type of food that we're ingesting. Also, it is very important for the patient to rest. Again, because we are suppressing the bone marrow, we are also suppressing the immune system. We have to remember that chemo or anti-neoplastic agents cause toxicity, and they're very toxic. It affects rapidly growing normal cells as well as our bone marrow, hair follicles, and our GI mucous membrane cells. Labs and diagnostic studies, so blood work as well as biopsies and clinical manifestations are used to diagnose cancer, or depending on what cancer we are talking about. So sometimes physicians or specialists will diagnose the patient differently depending on their specialty and the actual diagnosis. Staging, we use the TNM staging. It is based on the extent or size of the tumor, the extent or spread to the lymph node, so that's N, and the presence of metastasis, or M. So again, our staging is often based on the TNM staging based on the tumor, the lymph node, and metastasis. Complete blood count is very important to know, right? Because we know that anti-neoplastic agents can suppress the bone marrow, therefore causing decrease in red blood cells, decrease in white blood cells, and decrease in platelet. And as we previously learned, we can treat those side effects. So a decrease in RBC can be treated by epoetin alpha, a decrease in platelet can be treated by oprelvekin, a decrease in WBC can be treated with filgrastim. Another lab that we monitor again is your chemistry panel or renal function test, especially when we know that we are administering a drug that is quite nephrotoxic. Another lab work that we tend to check or monitor is the CEA, or carcinoembryonic antigen. So this protein is normally found in tissue of a developing fetus, so an unborn child, and so usually in adults that drops significantly in the blood. But then if we check that marker or CEA, when it's elevated, that's often an indication of possible cancer. There are other possible reasons for CEA elevation, but that being said, whenever that's elevated, we need to investigate further and not assume that it is caused by something else other than cancer. Tumor markers. So these are biomarkers. There are different tumor markers depending on what type of cancer that we are talking about. So these markers or biomarkers are produced by cells, both unhealthy and healthy cells. So these substances are found at a higher than normal levels in the blood, urine, or body tissue of some people with cancer. At times, there needs to be a lymph node biopsy to see if there's cancer in the lymph node or if there is a spread or metastasis of cancer in the lymph nodes. We also do CT scans or computerized axial tomography scans to determine the location, size, and characteristic of the tumor. In addition, we also use PET scans or positron emission tomography. This is done by using radioactive tracers, so sometimes this can be swallowed, inhaled, or injected, that can reveal the size, shape, position, and function of organs, as well as the presence of cancer cells in the body, which is usually indicated by white spots. Lastly, cardiac echocardiography or echocardiogram. This is to determine the ejection fraction or the function or the pumping ability of the heart. As we talked about earlier, there are medications that can be cardiotoxic, and so it is important to assess for the ejection fraction of the patient before and maybe after the treatment with such drug. Patient education, it is very important, especially in cancer, right? To give our patient and their family sufficient or adequate patient education about their disease process, diagnosis, the treatment plan, and instilling hope when appropriate, right? We have to also be realistic, and also we need to know our role. We don't diagnose. We are not the first one disclosing to the patient that they have cancer. This education piece are all reinforced. We're not the first one to say it. It's not the first time that they hear it from us. It should be coming from the doctor or specialist seeing them. In addition to those, we need to educate our patients pertaining the action of the drugs, the side effect, and how to manage it, such as nausea, vomiting, the importance of pre-medication, and PRN or as needed medication. In addition, we also need to tell them about their skin or mucous membranes. So with chemotherapy or anti-neoplastic therapy, it can cause dryness, itchiness, redness, healing, and other forms of rashes or sensitivities can happen when they're receiving these drugs. Weight loss can happen as well as hair loss, and in addition, it is also imperative that we tell them that they will feel fatigue and they're gonna be at risk for developing infection, and as well as the terminologies, right? The nadir. So nadir is basically the lowest level of neutrophils reached during therapy. So at least if we're talking about something, right, they have somewhat of an understanding of what we are talking about. And again, emphasizing that anti-neoplastic treatment can cause myelosuppression or bone marrow suppression, which will decrease the WBC, the red blood cells, and the platelets, therefore increasing the risk for infection, causing them to be hypoxic and feeling fatigue, as well as being at more risk for bleeding because of that decrease in platelets. Sometimes we may use antibiotics to prevent and treat infections, especially if we know that their immune system is quite weak at the time of treatment.